Okay, assalamu alaikum. I hope everyone had enough time to stretch, maybe grab some water. My name is Daniel. Alhamdulillah, I'm currently the executive assistant for MMAC. I'm also currently in my final year of undergraduate studies at the University of Toronto. Prior to getting to our final session of the conference, I wanted to quickly revisit some of our housekeeping items. So speakers are happy to answer questions during the Q&A period, which will happen once we finish the session. So please use the Q&A feature, put your questions there, and we'll get to them inshallah at the end. Once the conference concludes, right at 9 p.m. actually, we will send out an email, and in that email there will be a link to a survey, and that's our feedback survey. We'd really love to hear from you, your thoughts on how the conference went, and especially if you're looking for your accreditation, for which the entire conference is eligible for, including the poster session. Please make sure to fill out that survey. You'll have the email will be sent tonight, and you'll also have the reminder email tomorrow night. And once again, as this is our final session, please feel free. I really encourage everybody to post on Instagram, Facebook, Twitter using the hashtag CMMHC2022. And finally, if you're looking for more resources, we put a lot of work into our website, so please visit muslimmentalhealth.ca. Now, without further ado, let's get to our final session, where we'll be focusing on navigating common school and learning challenges as a Muslim parent. Our two speakers for today, I'll introduce the first one. Dr. Bazaid is a recognized academic and healthcare leader with the Department of Psychiatry, Division of Child and Adolescent Psychiatry, and undergraduate education program at the University of Ottawa. Previously, Dr. Bazaid has played an instrumental role in establishing child and adolescent psychiatry services and subspecialty training in Saudi Arabia and Middle Eastern region. Dr. Bazaid is the founder and course director for 4 consecutive years of the International Child and Adolescent Psychiatry Review course that was held for the first time on April 15 to 17, 2013 in Jeddah, Saudi Arabia. Dr. Bazaid is also the founder and course coordinator of the first Ottawa Child and Adolescent Psychiatry Update course for primary care. This was held September 13th, 14th, 2019 in Ottawa. Dr. Bazaid is a member and chair of CACAP Education Committee and a member of the WPA Presidential Working Group on Medical Students. Dr. Bazaid has published in peer-reviewed journals, has presented nationally and internationally. He's a primary clinical and research, his primary clinical and research interests include ASD and developmental disabilities, global mental health, child and adolescent psychiatry training, and undergraduate medical education. Dr. Bazaid has received multiple national and international awards for his work. The most recent one, 2019 Canadian Academy of Child and Adolescent Psychiatry Excellence in Education Award. Our second speaker, Dr. Zubairi, is a physician, researcher, teacher, and advocate. He's currently a developmental pediatrician at Ron Joyce Children's Health Center and medical director for the McMaster Children's Hospital Autism Program in Hamilton. Dr. Zubairi is an associate professor of pediatrics and program director for the pediatric residency program at McMaster University. He has also served as chair for the Physicians of Ontario Neurodevelopmental Advocacy, known as PONDA Network. So without further ado, I'll hand over the floor to Dr. Bazaid and Dr. Zubairi.
Jazakallah. Thank you, Danielle. Assalamu alaikum wa rahmatullahi wa barakatuhu. Bismillah ar-Rahman ar-Rahim. In the name of Allah, the most gracious, the most merciful. Really quite the honor and privilege to be here with everybody. I know it's late in the evening on a Sunday, and so for that we are grateful. I'm going to be co-presenting with Dr. Bazaid, and just for reference, this morning when Dr. Awad spoke, she was joining us from a different time zone. Dr. Bazaid is actually joining us from Saudi Arabia, where it's currently around 4 a.m. And so just want to speak to the testament of the organizers and putting this great conference together, and the folks that are really going above and beyond to bring forth to you an important topic. And so just want to make sure that Dr. Bazaid, your video is working and that you're able to be on. That's perfect. I see you. So we have a number of slides that we've put together on a very big topic, and inshallah, I think our hope is that we can use this time to go through the slides, but also address your questions. And we'll keep an eye on the chat box and the Q&A. So inshallah, if there are questions that are coming up, happy to pause the presentation and help address, what questions you have, and recognizing that the focus of this presentation is really around supporting Muslim parents, but there are obviously professionals, members of the community, and folks from across, various streams when it comes to thinking about mental health and the care of children and youth. So with that in mind, inshallah, again, really thank you for being here, for taking the time, and between the two of us, we don't have any specific conflicts to declare as it relates to the presentation that you're going to be hearing in what follows. And just to remind folks that really, what we are presenting to you, and this has been shared throughout the day, is information that we're bringing from our perspectives, but it does not replace actual medical advice from your child's actual healthcare provider, should you be a parent or someone who's seeking support and advice that is medical in nature. And so inshallah, just, obviously, if there's specific questions that come up about your child's specific scenario, we'd be happy to discuss that generally, but won't be able to talk about it in specifics to ensure that, the questions that you're asking are broad enough and general enough for everybody that is here to benefit from. So our objectives in really coming together is to think broadly around neurodevelopmental learning challenges that are encountered by children, with a specific focus around ADHD, or attention deficit hyperactivity disorder, and learning disabilities, to think about and review common misconceptions regarding diagnosis and treatment, to start to think about some of the barriers to treatment and the sequelae or the consequences of untreated learning conditions, and also to have you as parents and providers to have a framework around thinking about navigating school and learning-based challenges. And then finally, to begin to have the conversations, and this is obviously an area that could span an hour in and of itself, around some of the racial and cultural considerations when it comes to the diagnosis of ADHD and related neurodevelopmental disorders in BIPOC communities, particularly BIPOC Muslim youth. And so where I wanted to start, and what our hope was, is that we want to come at this really at a broad level, recognizing that, what you're about to hear are a number of terms. There's a number of language that kind of, gets thrown around: ADHD, autism, ASD, learning disabilities. But ultimately, when we think about children, we think about them as individuals that are coming to see us in our day-to-day clinical settings, in interactions with teachers and interactions with other folks in the community, and that each child really presents with us toileting, communicating, socializing. And so sometimes we might lose that perspective and that focus when we get, sort of fixed on specific diagnosis. And ultimately, as a medical provider, we do still have to think about that, but we don't want to lose sight about the fact that who we're working with are individuals. And on top of that, each of us represents, a diverse set of cultures, a diverse set of histories, a diverse set of experiences. And so what becomes really important for us is to try to identify what are the best ways that we gather information about a child. One way is certainly our data gathering, and what we do when we take a history, when we meet a youth. But remember, there's many sources of information that come beyond a clinical encounter that we may have, and that may be through teachers and other allied health professionals that are working with the child in a number of different settings. And so I sort of highlight that to say, again, we're going to be talking about a number of different terms. We obviously don't have the time to go into each diagnosis that we might see in a day-to-day clinical context, but there are many. And at the end of the day, they may influence one another, they may interact with one another, and the older a child, the more complicated it can become for us to tease some of these things apart. But there are guidelines, and inshallah, we hope to share some of that with you, just to spark some understanding and to build on what you're already aware. And so I'm going to hand it over now to Dr. Bazaid to begin discussing ADHD, and inshallah, we'll continue to loop back as we go through some of these pieces. Dr. Bazaid.
Thank you, Dr. Zubairi, and assalamu alaikum, everyone. I'm happy to be here and part of this wonderful conference. And I was cognizant of the time difference when I was invited to be part of this conference, and I couldn't resist. The importance of the topic, but also equally, if not more important, the participant, and it's under the umbrella of the Canadian Muslim Association. So it gives me an honor to be with you today, and also to be a co-presenter with Dr. Zubairi from McMaster. Before I go any further, I just want to shed light on this presentation. It is geared more toward the parents, maybe some youth and children are also present. I'm not sure how many they represent. I can see that there are 78 participants, including us. So I wonder how many of those participants are parents versus professionals, and maybe themselves as parents as well. But anyway, we try our best to present it as easy to grasp, to digest. But the floor, the floor will be hopefully toward the end, not toward the end, but hopefully half of this presentation where we can interact and hear from you, hear from us, and hopefully toward the end it will be a fruitful, dynamic, interactive presentation. So ADHD, or attention deficit hyperactivity disorder. Before we discuss this slide, which is part of the DSM-5, the American Psychiatric Association Diagnostic and Statistical Manual, which is accessible. Anyone can read it, anyone can educate themselves about it. But before I get into that, I want to also share one important information on how scientists, research speak, and what is about these disorders, and what's the common language. So we use, as you can see, something we call descriptive diagnoses. In mental health, most of the disorders are actually made and developed based on first observation and further studies, and then continue to be reevaluated over the years. And then the consensus among the scientists, they come up with these diagnostic criteria, as we can see. And this is applied to medicine in general. But some, they also can be associated or may be associated with some biological findings, like you can grow a bacteria in the lab, or you can find low hemoglobin indicative of, for example, maybe anemia, or low or high thyroid and stuff like that. Not many, if any, right now in psychiatric disorder necessarily have the privilege to prove it in the lab, but definitely it's all has been carefully examined, re-examined, re-evaluated over the years, and evidence-based study. So this is just one important information you have to keep in mind. So things similarly apply to ADHD. The name has evolved over the years from just ADD to ADHD attention deficit hyperactive syndrome, to all the way when it was and continued to be the name, with some variation in the recent edition that published in 2013. So from this group of symptoms, we came up with two main symptoms: inattention, like this is a group of symptoms, and then the hyperactive impulsives. Usually, we like to see these symptoms at least present before age 12. It used to be age 7, but that was changed in the recent DSM. And then the symptoms at least present in two different settings. Most of the time, home and school, but it can be mom, dad's home, but it can be also grandparents' home. In some cultures, like in the Middle East and the Muslim Arab culture overseas, even aunties, brothers and sisters, neighbors sometimes can sometimes be a source of information when it comes to diagnoses. And it causes clear interference in functioning, development and functioning. That includes school, social, family, work, etc. And it's not better explained by another mental health disorder. And as Dr. Zubairi mentioned in the last slide, there is overlapping between different disorders, so we have to be careful before we confirm or label someone with a diagnosis. And not anymore that we exclude the pervasive developmental, now it's known as the autism spectrum disorder, so it's not anymore an exclusion criteria. Can we switch to the second slide? Yeah. So when it comes to the, as I said, there are two main groups in diagnosing ADHD, the inattentive group and the hyperactive impulsive group. And there are three types, or they call it the predominantly inattentive versus predominantly hyperactive impulsive, but it can be also combined. And among the symptoms of under the inattention, you can read it yourself, but typically the story we hear from parents, reported through the school teachers and maybe others, that the child, the youth, the adult do not pay enough attention, cannot focus long enough to complete the task. And as a result, they are easily bored, distracted, preoccupied with anything else but what they're expected to do. And that also affects the memory, the processing of information, recall of information. And you can ultimately conclude it will affect their performance, no matter how gifted, how normal IQ, and how committed, and the parents, of course, putting a lot of effort to make the child, the youth, or even the adult attend to their expected tasks. And also they tend to forget, and there are always gaps in their memories. As for the hyperactivity impulsivity, which is the following slide, there are again two groups indicative of hyperactivity versus impulsivity. And we need at least 6 out of these, like we said in the inattentive, I forgot to mention, we need 6 symptoms. In the adult, 5 will be enough, according to the DSM. Again, these kids are loud, noisy, intrusive into other business, interruptive to the class, VGD cannot sit in one place for long enough. It's not about them do not want to follow instruction, but it is really difficult for them to maintain quiet and to sit in the same place for long enough. So they will be running, climbing, risking themselves into a lot of behaviors, and difficult to play quietly, which make it difficult for other children to like them. They end up rejected, they end up pushed away. And if we have time, I would like to talk about what that leaves with the children, how they feel that how they belong to other kids, and how they see the surrounding perceiving them. And they can also and that can also be manifested as sometimes impulsively, take things that does not belong to them. We see it as stealing, maybe when they go to let's say a mall or something. Of course, there are impulsive disorders and shoplifting, as people probably know about. But in the case of ADHD, they do sometimes things impulsively. I'm not here to make excuses, but it is my duty to help explain what's behind this unacceptable behavior socially. And we continue to review the symptoms, but something have to keep in mind, and this is well known to professionals, presenting or bringing a child with inability to focus, for having difficulty memorizing or forgetting things. Needless to say, teachers kept reporting this over and over, does not make him have a case of ADHD right away. We have to be careful. We have to examine the child in the clinic or in the examination setting, but also have a good history report from school, and as we said, from different, at least 2 different settings. But at the same time, do a due diligent job of examining other possible diagnoses, as Dr. Zubairi already mentioned. They're quite overlap. There is a lot of overlapping between different neurodevelopmental or functional disorders. So we have to make sure we're not missing a learning disorder, other disruptive behaviors of like opposition and defiant conduct. In fact, ADHD before used to be under the same umbrella of ODD, opposition and defiant and conduct, but not anymore. And I'm glad it's not anymore, for different reasons, for different good reasons. Mood can affect either way, high or low, the ability to focus, to maintain attention, to memorize, to remember, and so on and so forth. Anxiety, big one. If not sleeping well, or if having disruptive sleep, definitely can affect the physical well-being, the mental well-being, including the cognitive functions. Of course, substance use, medication-induced symptom of ADHD. But also, in addition to the above, there are some physical problems that can also cause or present like ADHD, like low in thyroid function, low in hemoglobin or anemia, if you may call, bronchial asthma, and some other like seizure-like, diabetes, and so on and so forth. And needless to say, impairment in hearing and vision. Just quickly, we shed light on how common the ADHD. The most consensus finding among the statistical studies, although depending on the design of the study, but the most consistent one, it's about 5% in children, 2.5 in adults, according to DSM. It can go higher than that, as in some studies, but ranging between 216 according to what reference you're reading. So it is a common diagnosis, more in males than in females. And the younger the child, the more common it is among male than females. And parents reported history of ADHD increased 43% from 2003 to 2011, while medication use increased by patient. And I hear it all the time. I don't like to put my patient, my child on medication, needless to be using it for the rest of their site. So people are more aware about the existence of ADHD, are more willing to seek help, and more receptive to treatment recommendation, which we will shed some light and we'll talk about evidence-based. So it's not just like something arbitrary we were describing. So we'll talk more about it. What causes it? This is a neurodevelopmental disorder, and it is a biological disorder. And among the many neurodevelopment disorders that we know something about, the possible causes, and it's highly hereditary, up to 0.76 when we compare it to the inheritance of height. And typically when we look for the history, we ask the parents about themselves when they were young, and the usual suspects are the fathers. If they are forthcoming, they will tell you, yeah, I was receiving a lot of similar comment like my son, but back then nobody paid close attention or been accepting of the ADHD, and you have to grow and out of it, and you have to apply yourself more in school and so on and so forth. So hereditary factors is quite high. Non-genetics are also common: low birth weight, prematurity, maternal smoking or drinking alcohol during pregnancy. During time of delivery and shortly after delivery, there are many factors can affect the neurostructure and neurochemical of the brain, and we will come to that in a minute. No single gene can be identified, and that's applied to many neurodevelopmental disorders and psychiatric disorders. And from a brain structural point of view, there is a clear evidence that there is dysfunction in the corticostriatal, the thalamic cortical loops. And when it comes to the specific neurotransmitters, the most commonly suspects are norepinephrine and dopamine, which are available in the basal ganglia and different places in the cortical precortical region. Yes. Other environmental factors I've already talked about. We can skip that one just for the sake of the time. And psychosocial adversity, family conflict can be a cause, but it's not necessarily a direct one. As I said, it's primarily a biological disorder. Inconsistent parenting can cause a child disruptive, irritable, not easy to follow instructions because he or she herself were not brought in a predictable way, and so on. But one thing I would like to emphasize here, which was mentioned in one of the earliest slides, parents are not the cause of ADHD. Indirectly, they may contribute to the making and the manifestation and worsening of the symptom, but they're not a direct cause of the ADHD. So we shouldn't be unnecessarily, unjustly blame ourselves. I think we'll continue, but with Dr. Zubairi now with the rest of the slides.
Jazakallah. I mean, there's so much here for us to unpack, and each of these slides that we're going over right now, we could spend an individual hour reviewing all the details about. And I think this, before I start talking to this slide, it's important for us to recognize that, as one of our objectives, there may be tendencies in certain situations, in certain settings, whether that's school or in the community, where folks may be quick to jump to a diagnosis and to suggest a diagnosis. And I think to Dr. Bazaid's point, there's always the risk when we think about certain communities where prematurely making a diagnosis may potentially have its own set of harms, and a diagnosis may be inappropriately given. And so I think one of our key messages and things to think about is that there is a process by which a diagnosis is made, and it can't just happen within the span of a few seconds or a few minutes of interaction or indirect observation. There's a lot of data that's needed, and we do know from the literature when we look about neurodevelopmental diagnoses about how our children's brains develop, and then the related consequences of that is that many times in ethnoculturally and racialized communities, there may be either inappropriate diagnoses that are given, or, for instance, there's a delay in the diagnoses. And that could be for a number of different variables. And again, we're happy to talk more about that. But it is important for us to think about that as part of our own, ongoing conversations as a community of health professionals that is working with families from a variety of different backgrounds backgrounds and contexts. This slide really just says that it's not common for ADHD to exist alone. Many times there are other developmental diagnoses that we have to be thinking about, asking questions about. And I know we've said this a few times, but it is really important because how we begin to approach helping an individual, a child or youth, is going to depend on what's driving their difficulty. Is it the ADHD symptoms? Is it anxiety symptoms? Is it more related to their learning issues? And again, all of these things can be related, and so we don't want to lose sight of that. And much work has been done looking at the combination of these. I did want to briefly just talk about learning disabilities, because that we sort of highlighted as one of the key pieces, because we often will say, is a child unable to pay attention because they process the world differently as it relates to their thinking and learning skills? And so this becomes important. And then on the other hand, are they having difficulties with learning in different areas because of their inability to pay attention? And so sometimes teasing that out can be tricky and takes time and takes a lot of information. But the resource that we've been referencing, the DSM-5, also highlights and goes through very specific criteria, which again are publicly available, to define what it means to have a learning disability. And the metaphor that I've often used is that inside our brains, we all have a certain set of tools, and those tools are based on our ability to work through the world by language, so what we read, what we understand when we communicate, but also tools that are non-language based, so things like puzzles and blocks and our visuospatial abilities. And so there are tests that are designed to look at those tools, and so we might find that there's an individual that has a certain level of tools available, and they would be expected to perform a certain way in terms of their academics in the areas of reading, writing, or mathematics, but for some reason they're not. And so that gap is what we often, at a psychology level, and this is, at a simplification, that gap between where you're expected to be performing and where you're actually performing is often what gets captured as a learning disability. And again, that's not a diagnosis that is made loosely by physicians. It can be suggested, often requires something called psychoeducational testing, that may be done through schools, may be done through privately or through children's treatment centers. Again, it will vary a little bit regionally, but that will give us information in terms of what are the areas of difficulty in the spaces of reading, writing, and mathematics as being broad categories. And again, you've probably heard, terms like dyslexia and what those mean. Dyslexia is a type of learning disability. And there's many others. And again, just to highlight that there can be overlap between what we're seeing on the outside of a child in terms of their ability to pay attention or focus could be coming from an area of difficulty in actually being able to think and learn about a problem that they're being presented with within the school context or in other settings for that matter. We won't spend too much time here, but just to again highlight that it is important for us to think about the long term. As developmental pediatricians, as child psychiatrists, as teachers and educators, we're often trying to understand, what is the long-term impact of a diagnosis for a child. And there is data to suggest that, up to 60% of individuals, of children that are diagnosed with ADHD will exhibit symptoms into adulthood. And we've already heard a bit about how common it is in the different groups of children and adults. And the symptoms may look a little bit different as well. When we think about the childhood presentation or the adult presentation, what we're going to see is going to be a bit different, and the context or the environments in which symptoms may show up for an adult might look different than for a child. Again, thinking about work environments being the most common, and also the demands that are placed on an adult are going to look different than for a child. And so it is important for us to think about that. But there is this continued recognition of how this progresses over time, and why that's important is because by intervening early and supporting children, youth early, we're hopefully able to change and influence and support and help children develop skills to make that movement as they transition into their teen years and into their adult years. And so finally, before I hand it back to Dr. Bazaid, I think, again, it's important for us to think about transition times. As a developmental pediatrician, I'm constantly thinking about the developmental impact. This can show up, ADHD symptoms as a behavioral disturbance when children are very young, as an academic area of difficulty as children get older. Dr. Bazaid was talking about social interactions and the impact on the ability to engage with other people, similar aged peers. And then certainly as you progress into the adolescent, college, and adult level, the challenges that can emerge with more high-risky behavior. And we've heard a lot about that through the course of the day today, ongoing difficulties with work environments, relationships, self-esteem considerations, as well as, again, into adulthood, thinking about those different environments. Dr. Bazaid, was there anything you want to add to this slide before we get into the facts versus myths? Because I think this is an important long-term picture for us to take into account.
I like to make just one comment. Dr. Zubairi, we've had 4 drafts of our presentation. On one hand, we wanted to bring as much as possible, but in the same hand, we wanted to make sure we don't exceed the 1 hour. We talk in a language that will be understood by our audience. So one of the things, as much as people see it as a negative impact of ADHD, and I will just make it a simple language, ADHD can produce criminals. And this is something scary to me, because they are not born criminals, but if they are left alone, not detected early, no intervention early, so then no wonder they are prone to make impulsive mistakes. They get themselves into substance use to overcome the anxiety, the depression that eventually develops over the years, and find ways to accommodate in a life situation where they are lost and they don't behave necessarily with the quote unquote the ordinary people. The point I wanted to make sure here to share with you, they're not born criminals. If we do intervene earlier, hopefully we can help them to belong to the mainstream, and if not, some of them, in fact, if time allows, we can talk about it. The daydreaming, the thinking out of the box, sometimes make some of them are gifted, in fact, and quite exceptional in a good way. So this is my addition to it. All right, so this takes us to some facts and myths that sometimes we come across, especially in the time that we live. Everyone has access to information through online sources. And then again, a word of warning, not everything you read can be necessarily a representative of the evidence-based knowledge. So you have to be careful. It's the individual responsibility to look and to check the sources that they're reading through. And when it comes to ADHD, we are really privileged in Canada to have CADRA. We have a lot of information, evidence-based, and easily available. Some are free for us to access. So we have no excuse if we wanted to read about what is authentic, what is scientifically based about ADHD, inshallah. So some facts. I don't think, of course, before I start, that this slide will be enough to go to argue for or against in few minutes. So out of respect, I have to say that to everyone, but we will do our best through the remaining slides. Hopefully we can support what we are talking about. So as I said earlier, it's highly hereditary disorder. It's under the neurodevelopmental umbrella, and it has high comorbidity. As per the slide presented earlier, if we talk about if there is any pure, depending on what's the developmental phase, you see the child, but or the youth, of course, as the adult, including the adults. So if we are talking about pure presentation of ADHD, it's not more than 25%. So the remaining are actually comorbidities. So you have ADHD with anxiety plus minus depression, ADHD with learning disorder, almost 30 to 40% in some studies, ADHD with substance use, ADHD with or physical disorder, and so on and so forth. So this is something to keep in mind, not just at the time of diagnosing and making those labels, but also it comes when we plan for the treatment intervention. It's across the lifespan, so it's not just one-time thing or early childhood and then completely disappear later on, because some of the myths that we hear from even among some professional, hopefully not anymore, but I remember in the 90s when some even professional from overseas particularly, they will say just, it's a boy thing. So you have to consider the normal, as they would consider it, normal male gender variations. So this is something people like to see, to believe in it. And we have also to keep in mind that some of the disorders, as I mentioned earlier, can be indirect benefit or a result of bad parenting, but it's not the direct dose to the ADHD. Some of the good things that evidence-based, scientifically proven over and over, that they respond well to treatment, and they actually we can have better outcome of these disorders, if you want to look at it in a brighter way, versus some myths that people, I would say, fully understand their concern, parents in particular, that if they read about the first line treatment of ADHD, it's a stimulant, which is amphetamine or amphetamine salts. So in the street, all what they know about amphetamine is an addictive substance that if people take it, they will become addictive to it, and that can lead or open the door to other illicit drugs. But in clinical practice, and studies has shown that consistently, it does not there is no direct cause relationship between using stimulant with kids of ADHD to make them more addicted. In fact, studies showed for those ADHD, if they don't treat it, if they are not receiving treatment with stimulant, the risk of falling into the addiction is 3 times more compared to kids with ADHD on stimulant versus kids with no ADHD. There is, though, we have to admit that there is what we call it the risk of diversion. As I said, it does not cause addiction, but some kids' ADHD can be because of the impulsivity, because they find that the benefit of taking the stimulant, so they give it to non-ADHD, which they may fall into the trap of addiction. And I would like to conclude by the stimulant does not cause change in personality. Yes, there are some side effects, and it's our responsibility to educate the child, the youth, the adult, and the parents, the caregiver, of these side effects. Luckily, these side effects are not dangerous things to think about, and most of them, if, for example, if we monitor them at baseline and then 3 to 6 months periodically, we can reverse some of it. If it affects the appetite and the growth, for example, if it causes any elevation in the pulse and the heart rate or the blood pressure and so on and so forth. So overall, they're safe, and with the right doses for the right patient, for the right symptoms, with the baseline monitoring and ongoing monitoring, benefits outcome the risk, if any. Now that we will move to talk specifically on the treatment, I believe the next slide, we can continue, please. So,
sorry, Dr. Bazaid, there's a question that just come up related to what you were sharing. So I'll just share that with you, and maybe we can answer it live, if that's okay. The question saying there's quite a bit of literature online suggesting ADHD is a gift and that there's a correlation with high-functioning adults in business, executive, sports, etc. Is this a myth, or is the research-based literature supportive of this assertion?
Very good question. I always think about ADHD, if we wanted to see it through a brighter lens, as a gift, and there is an opportunity to work along these lines. But I'm not aware, I didn't come across specific research on gifted ADHD, but we see it in the media, and we read about a lot, some celebrities, some producers in children and adults later on, who were diagnosed at some point with ADHD. So yeah, I do see that this is a good point. All right. Thank you. We will move to the treatment intervention. To the next slide, please. So this is, again, I will leave you to read it, but I will make as much that I'm looking at. We're already 8:46, and I was hoping to have more time for interaction and questions from the audience. But in general, I would like to say that there are general outlines to treatment. Dr. Zubairi already talked about, and I've also mentioned it in the beginning, it's not just of a one-time diagnosis, and same thing applied. It's not just one-time recommendation, but rather working with the child, youth, and the adult on an ongoing basis. So the treatment, it's biopsychosocial, means we address the biological interventions through stimulant, and has been proven to be, compared to other disorders, to be quite effective. There is no time to talk about the specific studies, but definitely has been proven, replicated in many studies to be quite effective. And Dr. Zubairi maybe will shed light on that, or how the medication works. However, when we look at the other aspect, it is equally important like medication. So medication will not make your child, and I give the example of the eyeglass. It will make him see the road, the path, but will not make him do the action. So we have to work with the child, with the family, and the youth, of course, and later the adults, to acquire the missing skills, the time management, the organizational skills, and on work collaboratively with the school, with the works, with the work setting, and life in general. So it is a treatment applied for the individual within the setting where he or she is expected to function, be it a school, home, work, on the street, and so on and so forth. If we move on, we can specifically talk about a few things. At school, I will leave you read through, but one thing that we need to, from this slide, to a message to take home, as health professional, we have to support our children, youth, and later even adults, if we come across that, by providing accommodation at school, like individual education plan. Sometimes I write detailed letters of what do I expect from the school, for all the youth ready to go into post-secondary school. I use the cadre guidelines to indicate what expected and what additional tools or accommodation during like assignment time, exams, especially when in college and university. There are assignment exams almost every week, or if not every 2 weeks, with a very short period of time. The professors will finish a lot, and the ADHD kids with ADHD, youth with ADHD, adults with ADHD may not be able to accommodate, not because they are not willing or they're not capable, but they lack the time management, the organization skills, as we highlighted earlier. So very important to be advocating and to help them with whatever we have. The next, please. Maybe we can move, because I'm just conscious of the time. We can, yeah. There are some social skills, definitely. As I said, can be geared toward the ADHD symptom itself, or the manifestation or the co-occurrence, the comorbidity of other stuff with the ADHD, on top of the ADHD, like anxiety and depression. So we have to work with the youth, with the children, youth and adults, to address the anxiety, the depression. And there are a lot of evidence-based tools or therapeutic modalities like CBT, cognitive behavior therapy, mindfulness training, and so on and so forth. And of course, there are also training for the parents, but I don't think we have time to highlight all of that. Next, please. I believe, yeah, I'll turn it to you, Dr. Zubairi, to continue.
Perfect. Jazakallah. And for those folks on the call that attended Dr. Farah Islam's talk around addressing mental health issues within the school context, she was referencing a number of the resources as it relates to supporting children's mental health well-being, and many times there can be overlap. Dr. Bazaid has alluded to this already, but again, thinking about medication as a pair of glasses is certainly one way for us to begin to consider how medication gets factored in as one treatment option, and one that has evidence. And again, we could spend another hour or so talking about medication in and of itself. The other metaphor that I use, that I think about, is around volume control. No medication out there will take any neurodevelopmental concern or behavior or difficulty and bring the volume down to zero. It may bring the volume of concerns down a little bit, but you still have to then focus on all the other strategies to help children build skills and be able to use those skills across different environments. I also use this to say that, many parents will have concerns about side effects and what things that, medications may do to their children. We acknowledge that, any medication that's addressing things in our brain can do the opposite of what it's intended to do. And so we have to monitor for that. And our responsibility and follow up, and to, as we're seeing kids at the 6-week mark or the 6-month mark, is to ask questions to make sure that, the best medication's been chosen to help support, in addition to all the other things being done as well, right? So again, this is not meant to be in isolation. I have said that. And so before I get into this, I do see that there may be another question. So I will just go ahead and start. Maybe folks, if you want to put in your questions in the chat box, we do have 10 minutes remaining, inshallah, and happy to answer. And we may touch upon some of these things. So the question that's being asked is, does all ADHD types have to be treated with medication? Do parents have the rights to only use psychosocial approaches since they may be reticent or I guess have hesitations towards drugs and have assumptions about them? What do you think about that, Dr. Bazaid?
Very good question. The simple, straightforward answer, no. Not every single ADHD needs to be medicated. However, it is not a decision to be made based on a concern of the parents, with all due respect, because they don't like the medication. It is a decision made bidirectionally or in alliance between the physician or the health professional and the child, youth, and their parents, and later on adults and their caregivers. So we look at the symptoms. Some kids with ADHD, they don't need the medication, but they need to change the setup, provide additional support at school. But there are kids, and these are the majority, and usually they are our teachers nowadays, I would say most of them in Canada at least, they're familiar with ADHD. So they tend to do already, they try their best to intervene and provide support, and it doesn't work. So it is important to realize that giving medication, as the nice example we give, is like an eyeglass. If your child cannot see far, no matter how close you bring him to the board and near to the teacher, close to the teacher, it still cannot see. You cannot be stubborn to the rest and don't take him for the exam check and have him wear the glasses. So the stimulant, if it's indicated, has to be done. However, as we said earlier, for the right person, the right dose by the right physician, and then we start at baseline monitoring and then continue to monitor it every 3 to 6 months according to the guidelines. I hope that answers the question. Equally important, not to forget by the model we mentioned earlier, biopsychosocial. So I give the medication, but there are also non-medication pieces we need to apply. Time to sleep at night, the time for play versus homework, the social skills, all the support at school, and so on and so forth. Yeah, so something to keep in mind.
Jazakallah. One of the other questions that's being asked now is, as an elementary teacher, almost every single student I have who's been diagnosed with ADHD, their parents have not put them on the medication due to side effects of loss of appetite, and they've all cited the same thing. I'm wondering what could be said or done in a role as a teacher in this case, as this has been an experience that's come up repeatedly.
Okay, we know that the appetite suppression is a common presentation. And again, when we prescribe, if it's indicated to put the child on stimulant, we start with weighing the child and then monitor that, and also the height as well. I tend to typically suggest that they take the stimulant before they have their breakfast. So that helps in a way. If it is not needed, some kids, they don't need it during the weekend, then they can skip the medication during the weekend. And during the holiday, if they're not expected to participate in a camp or go in or attend a program, personal development, what have you, if they don't need the medication, they don't have to be. So we can always compensate during the weekly holiday, the monthly or the periodic holidays, and at the same time monitor the weight and height. As far as the weight and height within the normal measures, I wouldn't, if it is indicated to take the stimulant, I wouldn't stop it. And I will encourage and educate the parents and overcome their concern by discussing it with them.
Yeah, Jazakallah. And I think that's such an important point as continued engagement and conversation, I think becomes really important. And often what I will highlight as we're thinking about medication is having a very clear discussion about what are we targeting with it, right? I'm surprised the number of times children and youth will come to me and they've been on multiple medications, but when we ask the parents, what was the goal of this child being on medication A or medication B, and many times parents aren't able to voice that. And I think there's an onus and responsibility and obligation on our part as health professionals and teachers and educators, obviously, to engage in that dialogue so that parents are making an informed decision about this. Again, first to acknowledge that it's never an easy decision, because again, there's so much other information that has come the way of families and their and children's caregivers. So it is that I love that notion of a bi-directional relationship that we have to engage in the dialogue. So
if you allow me, just one, before we used to talk about compliance, means a physician will prescribe and the patient is expected to comply. Not anymore. We call it now alliance, mean it has to be bi-directional. In making the decision, reviewing the decision, and working on the decision. Continue to work on the decision.
Jazakallah. I'm just going to run through, in the last minute that we have together, there's a number of different questions that get raised from families around medication. We've talked upon a few of these things. Why would I need to medicate? So that's the discussion about the targets. This question comes up about what will medication do to my child's brain? And will this turn my child, we were saying earlier, quote quote unquote into a zombie. And again, remember, we're looking at medication as a tool available to support an area of difficulty as we understand the biology. We wouldn't be prescribing something if we didn't have a sense of or an understanding of how that affects the biology of the child in the long run, and how to best support them, right? And so I think it's important for us to recognize that the goal of medication is not to change the child, but is rather to support the child in being able to function in the different environments. And that's what question 4 is again getting at. We've talked a little bit about options other than medications, but I think to reframe that question, many times medication is being used in along with other strategies based on the evidence and the guidelines that we have, particularly for children and youth with ADHD. And we were just starting to touch a little bit upon this around some of the appetite changes, and how to approach that, and whether or not a child has to be on medication forever. And again, we sort of see how the child's abilities change over time with skill development. And there are situations where, again, I'm love to hear from Dr. Bazaid on this too, is that how would you respond to that? Does the child have to be on medication forever?
Very good question. No, not necessarily. Again, you said it earlier. We were answering here generic questions, like in general. We were not targeting specifics. So we have to be careful on that. But definitely in my practice, I have seen children whom I put on stimulant, of course, in agreement with the parents and the youth or the child. And guess what? Not even all of them needed the dose as recommended, for example, 1 milligram per kilogram according to which medication you're using. Some I call it, all what they need is just the push that they needed, and then they will continue the journey. So eventually after 6 months, maybe a year more or less, maybe they don't need it anymore. Some kids by puberty time, they have acquired more skills in their own or through the teaching that they have received from the health professionals or at school, the support and what have you. But some, they may continue to be on medication for the rest of their life. And there are, again, I don't mean to spread something from other, but I've heard this from other patients that I use it whenever I need it. So there are patients whom they adopt this kind of habit or strategy. They use it as needed, but in general we recommend the stimulant if indicated, based on what symptom we are targeting, and then we look at the function, the development, and the improvement as a result. So yeah, I hope I answered that question.
Jazakallah. We'll just refer folks to the CADRA guidelines that we've talked a lot about, certainly as professionals. This is a great reference for parents. There's a sister website, a companion website, called CADDAC, CADDAC. So that would be something that is quite helpful for parents, is understanding of the various issues that arise. And again, we'll plan to now finish off just because we're a little bit over time here, but again, there's lots of discussions around different medications that are available on the CADDAC website, CADRA website, and I just wanted to return to this slide again intentionally, right? Again, alhamdulillah, Dr. Bazaid and I have shared a lot of information with you, but let's not forget that again, it's the child in front of you, right? It's your child, it's the children that we see clinically. These are people first, and then we think about all these other kind of terminologies and language, and it becomes a dialogue and an opportunity for us to think about how do we best support our children and youth as they kind of go through the different aspects of life. One other suggestion that just came through the comments is that if parents have questions about, medications or other strategies within the school system and advocacy, it's helpful to also connect with other parents that have gone through similar situations and may have had certain experiences. And there's a number of opportunities to do that as well. And inshallah, I'm gonna let Dr. Bazaid have the final word here, and inshallah we'll plan to finish up then. Go ahead, Dr. Bazaid.
Thank you. I was just touched by a comment from the chat. This has been an excellent presentation. Thank you. we did our best, and we still, Dr. Zubairi and I, we felt we wanted to have the right balance between how much information, but at the same time, being cognizant to what the people needs are. But definitely, we appreciate your dua to us, and we are here to help. And I still feel, Dr. Zubairi, that there are some areas that we probably need to explore in the future. ADHD is not unfinished business. And no matter how many times we talk about it, there's still something come up. And maybe the organizer might think another conference or a presentation specifically about different aspects and would love to see or to have our colleagues from the other health allied professional to be with us as well. But thank you.
Jazakallah. I don't know if folks from the conference wanted to come on. I'm just going to, because I know this is the final session of the day, but I will stop sharing my screen. 1 second. Here we go. But Jazakallah for having us, and it's been a great opportunity to hear from everyone. Jazakallah. Assalamu alaikum.
Wa alaikum assalam wa rahmatullahi wa barakatuh. Jazakumullah khair, Dr. Khalid Bazaid and Dr. Muhammad Zubairi. It's so nice to see you again, Dr. Khalid. So this concludes our conference, alhamdulillah. So what we are going to do now, I'm just going to play the resource fair video one more time so that all the attendees, inshallah, that you may benefit from the community resources that do exist. So I will play this now, inshallah, and then afterwards we'll just do a closing dua and recognize all of the hard work, all of the team members of the CMMHC organizing committee, inshallah.
طلع البدر علينا من ثنيات الوداع وجب الشكر علينا ما دعا لله داع أيها المبعوث فينا جئت بالأمر المطاع جئت شرفت المدينة مرحبا يا خير داع طلع النور المبين نور خير المرسلين نور أمن وسلام نور حق ويقين سكه الله تعالى رحمة للعالمين فعلى البر شان وعلى البحر شان طلع البدر علينا من ثنيات الوداع وجب الشكر علينا ما دعا لله داع أيها المبعوث فينا جئت بالأمر المطاع جئت شرفت المدينة مرحبا يا هيدا مرسل بالحق جاء نطقه وحي السماء قوله قول فصيح يتحدى البلاغ فيه للجسم شفاء فيه للروح دواء.
Welcome everyone. I would like to highlight a website called muslimmentalhealth.ca, whose home screen you should be able to see right now, barring any technical difficulties. So this is a website that is curated by the Muslim Medical Association of Canada to centralize resources relating to Canadian Muslim mental health. So it hosts resource lists, educational materials, as well as links to programs and services that you might find valuable. So I'd like to walk you through some of the website and what it contains. So the first tab here shows the Canadian Muslim Mental Health Conference, the conference you're attending right now, and its past iterations going all the way to 2017. 2019. The second is a research program called Inspiring Muslim Minds, which is done in collaboration with CAMH to reduce the stigma of mental health in Muslim communities. Under the resources tab, you will find a number of key links. So firstly, we have emergency and crisis services, which are resources broken down by province. So we have national resources, resources relating to Quebec and Ontario. The next section under resources, we have self-help, which are sort of Islamically themed mindfulness apps, for example, books, courses, podcasts, as well as other websites in the Muslim mental health and just mental health in general space. The next resource is psychoeducational materials. So this is more PowerPoint presentations and video content, including lectures and community town halls, as well as documentaries on Muslim mental health. Our final tab in the resources section is just additional resources on the mental health topics that you can see here. So briefly, I can show you our listing on anxiety, which contains slides and a lecture by Dr. Asim Youssef, and you can find that for any topic here. So to repeat, the URL for this website is muslimmentalhealth.ca. Thank you for your time, and I hope you enjoy the rest of the conference.
We officially started WANISA, Mental Health Services for Black Youth. We know that spirituality is a really big part of the work that we need to do, and so we honor the entire person by seeing spirituality as well. Whichever way that's defined by the individual, spirituality can just be purpose and meaning. What's important to that person? Our healthcare providers appreciate the importance of spirituality in the work that we do. They appreciate the importance of cultural safety. There are services, they just don't feel safe when you're Black. The access is different when you're a Black person named Muhammad trying to get those services that has a history of living in a place like Regent Park. Already the stigma that comes to you when you enter certain facilities is unsurmountable sometimes. And so in our space, you're safe. The people that you see look like you.
Hi, good afternoon, everyone. Thank you so much for having us today at the Canadian Muslim Mental Health Conference. It's such an honor to be here. Today, we're speaking about the Abrar Trauma Mental Health Services and its mission. It's an organization that is dedicated to provide affordable, trauma-informed, art-based, and culturally sensitive, competent mental health support for diverse newcomer and immigrant. Our services usually carried through people with lived experience, professionals with lived experience who speak our client first language. And our services are mostly one-to-one counseling, especially trauma counseling, family and couple counseling, support group, and psychoeducational workshops, art therapy workshops. Also, we run and lead few projects that are early intervention and need-based, such as the Deal by Deal, which is an early intervention currently being piloted in Kitchener-Waterloo. It's to support the new arrival of Afghan women, and Brave Space, which will be launched in 2023.
Assalamu alaikum. My name is Ali from Nasiha. I am the outreach manager at Nasiha Mental Health, and at Nasiha we provide 3 layers of service. Our first layer being our helpline, which features call and text service between 12 and 12 Eastern Standard Time, where anyone can seek support from a frontline perspective by our trained counselors and get the support they need. Secondly, web therapy, which is based off referral and an intake process, which allows clients and people who need the support to skip the wait times and skip the lineups and the financial burdens of having therapy and getting service from our registered clinicians. And lastly, education outreach, where we go to different schools, community centers, conferences, and work to end the stigma about mental health and show that Muslims care about mental health as well. And that's a bit about Nasiha.
alaikum and welcome to Canadian Muslim Counseling. Canadian Muslim Counseling offers virtual counseling and psychotherapy across Canada with a team of highly qualified and licensed Muslim professionals who are proud to offer confidential, safe, affordable, accessible therapy from holistic, empathetic, and Islamic perspectives. Some of these services we provide include individual, premarital, marital, family, and Islamic counseling. What makes Canadian Muslim Counseling so unique is our core values that are embodied all across our interactions with our clients, employees, staff, and even online across our social medias, whether it's on our Instagram or Facebook at Canadian Muslim Counseling. This is a sneak peek at our fall 2022 line, and you can find these at muslimmentalhealthapparel.com. Jazakallah khairan for your time, and if you have any questions, feel free to contact us at info@muslimcounseling.ca, or you can find out more about our team and how to book yourself an appointment with one of our licensed professionals. Find us at muslimcounseling.ca.
جئت شرفت المدينة مرحبا يا حيادا الله الله ما لنا مولى سوى كلما ناديت قال يا عبدي أنا الله طلع البدر علينا من ثنيات الوداع وجب الشكر علينا ما دعا.
Almost 6 years since Soli's tragic death at the hands of correctional officers at the Central East Correctional Center in Lindsay, Ontario, in which Soli was violently murdered and beaten to death by guards who were supposed to take care of him, which Soli had 50 bruises, in which both his legs and his hands were tied, in which he was pepper sprayed twice, and involving more than a dozen guards. Justice for Soli continues to fight for a better tomorrow for all Canadians suffering from mental illness, where they're treated with dignity within the justice system. And as a society, we must do better. And so I invite all of you to continue to support us in this journey, in this fight. And please come on December 17th at 6 p.m. at Dundas Square to ask for justice for Soli, but all Canadians suffering from mental illness. We must and we should do better as a nation. There should not be a double standard, one for law enforcement and one for the rest of us. Justice for Soli. Thank you so much. See you there.
What was your life like when you woke up this morning? Chances are you had a roof over your head and a fridge filled with food. Imagine a life in poverty. Children suffer. Health problems arise. Education is non-existent. 1 in 7 people in Canada currently live in poverty. Majority are single mothers, refugees, and racialized minorities. In particular, Muslims. Families have to choose between paying rent or putting food on the table. So how can you help? Many of the Canadian Muslims that are suffering are eligible to receive your zakat. When we invest our zakat locally, we are building a self-sufficient community, providing food, shelter, essential needs, and the support they need to succeed. Home is where we find love, peace, and tranquility. But home is not the same for everyone. Some have no home, and some aren't safe at home. Any given night, 6,000 women and children stay in an emergency shelter. 19,000 are turned away each month because there is no space. Nissa Homes is on the front line catering to Muslim women and children who have no place to go, helping them heal physically, emotionally, mentally, and spiritually from their trauma, and giving them the support they need. The demand for our services continues to grow, and we need your support. Because when we help the most vulnerable members of our community, we grow stronger. while they may have suffered alone, the only way we can heal is together.
We're Smile Canada, and for the past 14 years, we've placed ourselves at the forefront of the fight for inclusion. Because we believe that all children have the right to be included. With a dedicated community of volunteers, staff, and supporters behind us, we've been able to successfully serve over 500 Muslim and racialized families of children and youth with disabilities right here at home. We provide our Smile families with culturally responsive support and care through a wide range of programs and services such as back-to-school and winter drives to bring families much-needed supplies to prep for the start of the school year and the winter season. We also host Eid gift drives and Eid fairs to ensure every child has the opportunity to celebrate Eid, whether that's at home or in the hospital. Not only this, but we often host critical conversations with global and local leaders like Imam Khalid Latif and Sheikh Abdullah Oduro to further champion accessibility and inclusion for the diverse families that we serve. We have support groups in place offered in multiple languages for our moms, dads, and siblings to provide safe spaces that the entire family can trust to lean on. We also provide fun programming for our children and youth, like our arts and crafts workshops, summer socials, Quran and Nasheed workshops, and an after-school soccer program. Now that you know a little bit more about us, we'd like to welcome you to our Smile family. Don't be a stranger. Keep in touch and connect with us on social media.
We often advocate our community to seek mental health support, but when it comes time to finding a therapist, how do you do so? Introducing your go-to resource to find a Muslim therapist, ruhcare.com, a global directory of Muslim therapists, powered together with the Muslim Medical Association of Canada and more, is a free resource for the community to find a therapist aligned with their preferences. With more than 300 therapists listed in Canada and beyond, therapists are simply a search away. And dear Muslim mental health professionals, we are here to serve you. Get almost all the benefits of a conventional directory, but without the cost. 100% free, unlimited client referrals. Got a waitlist or not accepting new clients? No worries. You can set the status and still get exposure for future clients. Built by the same team behind the Ruh app, an Islamic mindfulness and contemplation app. And today, let's share the word at Ruh Care as a free resource to our organization's websites, and let's make seeking mental health support truly accessible for our community together.
All right, assalamu alaikum everyone. I just want to thank all of the volunteers, all of the speakers, the moderators, the judges, the research presenters, the abstract reviewers, and the judges. Jazakumullah khair, and especially to all of the attendees who want to learn more about mental health care, who want to learn more about the needs of our community. Inshallah, may Allah bless you all. So, Jazakumullah khair, we'll just close off with a short dua, inshallah. So, we ask that Allah help us organize this conference year after year, inshallah, to benefit as many people from the community. We ask that Allah keeps our intentions pure and that we are able to continue to actually benefit the community and translate this knowledge into work on the ground. May Allah bless all of the speakers. May Allah bless all of the shuyukh and the imams who are doing work in this area. And may Allah accept all of this work from us. May Allah provide shifa and a cure to all of those who are battling mental health issues. And may Allah help us in providing cures to those who are ill and in improving the mental health of those around us, inshallah. Allahumma salli wa sallam wa barak ala Muhammad alayhi salatu wassalam. Ameen ya Rabb. The last thing I will do is I just want to recognize all of the hard work that was done by our wonderful volunteers. So I'm just going to share a slide that has all of the names of everybody who was involved, inshallah. And in that, I will conclude the night, inshallah. Assalamu alaikum wa rahmatullahi wa barakatuh.
مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم محمد سيد الكونين والثقلين محمد سيد الكونين والثقلين محمد سيد الكونين والثقلين والفريقين من عرب ومن عجم مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم مولاي صل وسلم دائما أبدا على حبيبك خير الخلق كلهم